We will now address your questions in this live question and answer session. Please note we will address broad-based questions only. The speakers cannot provide specific feedback on your individual situation. This question and answer session is for educational purposes only and does not substitute for medical advice. Please talk to your medical team with questions or concerns about your individual care or treatment. Welcome back, everyone. We are very fortunate to have this incredible panel of NET experts join us for a live question and answer session. It's an honor to introduce today's participants. Dr. Cecilia Carreras, nuclear medicine physician from the Hospital Angeles Lomas in Mexico City. Dr. Jennifer Chan, medical oncologist from Dana-Farber Cancer Institute in Boston. Dr. Aman Chauhan, medical oncologist from the University of Miami Sylvester Cancer Center. Dr. Kalicia Clark, surgical oncologist from the Medical College of Wisconsin, Froder Hospital. Dr. Pamela Kuntz, medical oncologist from Yale Cancer Center and Smilow Cancer Hospital. Dr. Nadine Malak, radiologist and nuclear medicine physician from Oregon Health and Science University. Dr. Eric Mitra, radiologist and nuclear medicine physician from Oregon Health and Science University. Dr. Vineet Sukrathan, medical oncologist from Ohio State University Comprehensive Cancer Center, the James. And Josh Mailman, president of NorCal Carcinate and patient advocate extraordinary, who will be serving as co-moderator for today's question and answer session. We have approximately 85 minutes for our question and answer session that will be divided into two parts. I will moderate the first part of the question and answer session with Drs. Clark, Kuntz, Malak, and Sukrathan, and Josh Mailman will moderate the second part with Dr. Carreras, Chan, Chauhan, and Mitra. So I now invite the first group to stay on with me while Josh and the second group can now turn off their cameras. Thank you again for being here. And the first question is a very reasonable and common one. How often should we get scans? And Dr. Kuntz, I'm going to start with you. I mean, PET, CT, MRIs, how often should we be getting scans?
Thanks, Lisa, and hi, everybody. That's a great question, and it really depends on a number of factors. So it depends on the stage of the cancer, whether your cancer has been removed or not, whether it's metastatic, and it also depends on the grade or differentiation. I know you've learned about all of these things over the course of the day. So for example, for a patient who had a well-differentiated low-grade pancreatic NET that was resected, we might consider doing cross-sectional imaging following surgery and then annually for 10 years from the time of surgery. We typically use cross-sectional imaging as our primary tool to monitor patients. I get asked a lot about how often and when do we use gallium-68 PET scans or other types of DOTA PET scans. We typically will use those for patients perhaps at time of diagnosis and perhaps more frequently for patients who have metastatic disease, especially as we're trying to determine eligibility for lutetium dotatate or radioligand therapy. And I might just make one more point and then happy to have my other colleagues comment. For patients with poorly differentiated neuroendocrine carcinomas that are metastatic, we often will image more frequently. So perhaps every 6 to 8 weeks, unlike patients with metastatic low-grade NETs where we may image every 3 to 6 months.
Thank you, Dr. Kuntz, and especially for weighing in from the oncologist perspective. And Dr. Clark, as a surgeon, how would you answer this question?
So I think Dr. Kuntz really summarized that well. As a surgeon, we tend to get many of these images before surgery. So I tend to get a good cross-sectional CT scan with arterial and venous phases for surgical planning. Additionally, especially if there's disease in the liver and we're going to cytoreduce or debulk, an MRI of the liver is more sensitive than the CT scan of the liver. It gives us a lot more architectural information, and so that can help us in the planning of liver resection. And then a dotatate scan preoperatively is very important if we have a well-differentiated tumor to just ensure that I understand exactly what areas we need to be targeted, and so we can remove as much tumor as possible. The frequency of exams after that is really dependent on all of the factors that Dr. Kuntz mentioned, so I'm not going to repeat. But essentially, I think the summary is we usually use cross-sectional CT scans to follow patients at the desired interval. And the most common question I get is, well, why not survey me with a dotatate scan? And it's a very expensive scan. There are also false positives and false negatives. We tend to reserve dotatate scans for suspicion of recurrence and really try to not use them as a common tool for surveillance after surgical resection when all of the visible tumor was removed. So we rely more on cross-sectional imaging for surveillance and dotatate to confirm or to help us elucidate any suspicious new findings.
Thank you. We're honored to have both the medical oncologist and surgical oncologist perspective. Dr. Malak, what else would you have to offer with that? And also, there's actually a specific question about, is it possible for NET metastasis to not have diffusion restriction on contrast MRI?
Right. Hi, everyone. I would just emphasize that, yes, dotatate PET is something that we get for specific indications and not for routine follow-up. Except if the disease that's occult on CT and we see it only on PET, then we get those more frequently. But otherwise, we rely on CT and MRI and occasional PETs when there's an indication to get them. And for the diffusion restriction, typically neuroendocrine tumors do show the diffusion restriction, but also that correlates with the grade of the disease. So basically, there are papers that show that the higher the grade of the disease, the more diffusion restriction there is. So typically, they do show up on diffusion restriction, but the degree of diffusion restriction is very variable based on the type of tumor.
Thank you, Dr. Malak. Dr. Sukathan, at what point does active surveillance need treatment?
Oh, that's a great question. Thanks for asking that. So I think it's very variable. All of us know that thankfully sometimes neuroendocrine tumors can be quite slow growing, and we're all thankful for that. But at some point, once we start to see suspicious looking lesions, on a scan, a good anatomic scan, which is either an MRI, or a triple phase CAT scan, as Dr. Clark had mentioned earlier, I think that should raise our suspicion for maybe this is a recurrent metastatic tumor. But I always try to counsel patients that just because we find a spot, I don't think it necessarily necessitates that we need to jump and intervene on that, because all of us know that thankfully sometimes you can go many, many years with just active surveillance. So I think this has to be tailored to every patient's unique perspective, because I don't think it's a one size fits all approach. A lot of the times it depends on where the tumor is, how much tumor bulk there is, what the pace of disease is, which is an extremely important thing, which we can really only know with some serial imaging over 6 to 12 months. So I counsel patients not to feel overwhelmed with anxiety about small spot that was found on the liver, because as we all know, we have lots of good treatment options and the options are getting better and better every day. So I ask people to really know we have some time to figure out what is going on, what is the pace of the disease, and we can take our time to intervene. But a lot of it depends on the context, the symptoms, the pace of growth, and how much tumor there is and where exactly the tumor is.
Thank you for that answer. Dr. Coons, so when there is progression, is there benefit in staying on octreotide or lanreotide long-term, even if the disease is progressing?
I will say that we don't have clear evidence to use somatostatin analogs beyond progression. And with the exception for patients who have functional NETs, patients with a functional NET, meaning it secretes a hormone that leads to symptoms of hormone excess, those patients will be on lifelong somatostatin analogs. So I think that it's really thinking about, is a patient, do they have a functional NET or non-functional? Non-functional, I typically do not continue SSAs beyond progression. And for functional, I would continue that indefinitely.
Thank you. Dr. Clark, what are the current recommendations for confirmed pancreatic lesions less than 2 centimeters that have been stable or non-growing for multiple years?
So there's more data that really supports observation of small, non-functional, asymptomatic pancreatic neuroendocrine tumors. And it's really important for us to make sure that we're meeting all of those criteria. So they have to be non-functional. Only in the pancreas. There's no role really for observation of small bowel neuroendocrine tumors, for example. I do get that question a lot. And again, these must be asymptomatic. We've found out that there's some criteria that we can see on imaging that may tell us that these tumors are going to misbehave, even if they meet the other criteria. So the other thing that I look for is to make sure that the main pancreatic duct is normal. It's not dilated. It's not being impinged on by the tumor. Sometimes that can portend a more aggressive subtype of pancreatic neuroendocrine tumors that metastasize more frequently. Also, we want these to be PET dotatate avid. And again, that really underscores a well-differentiated tumor that is likely to be more indolent. And specifically, if possible, to get an FNA measurement of the Ki-67 and to document that it is a grade 1 tumor, which I tend to do for lesions that are above 1.2 centimeters in size, because we can usually biopsy those well. And if they're grade 1 tumors, then we can watch those. Tumors that are size criteria that I don't feel as comfortable watching, we just don't have as much data for grade 2 disease for sure. Makes me a little uncomfortable, even though there's some data that it's possibly okay. And if there's any abnormality to the main pancreatic duct, I'm always concerned that we're missing something else. But my preference is to observe these lesions as much as possible, as long as they haven't demonstrated any worrisome features, which are the ones that I mentioned before.
Thank you for that. And I'll ask a follow-up question, Dr. Clark, because there were a couple questions about the differences between an FNA, which you mentioned, if you could explain what that is, and a tissue biopsy, and how there can be differences sometimes.
Right. So essentially an FNA is a tissue biopsy. There's another kind of biopsy called a core needle biopsy, which is a larger needle. And basically all we're doing is looking at the size of the needle that's used to ascertain this tissue. An FNA is a much smaller needle. And so because of that, what we tend to have to examine with the pathologist are almost single cells. So the architecture is not quite as complete as like a bigger needle biopsy, but it allows us to be able to biopsy lesions, especially in the pancreas, through the GI tract, through the stomach, through the duodenum, without too much compromise. Essentially, to get a larger needle biopsy, it's not safe to go through organs as well with some of these larger needles. And so a core needle biopsy or a larger biopsy may require an external biopsy, more of a percutaneous route. But I think our techniques now for FNA are so good. At our institution, the FNAs are performed with a pathologist, so we have real-time assessment of the adequacy of the specimen sample. And so at our institution, these can be very accurate to help us identify the grade of disease.
Thank you for clarifying. Dr. Sukrathan, I'm going to shift this to you in terms of lung, because I know that you have a special interest in lung. How does a tissue sample maybe show normal lung tissue, but a needle biopsy confirm neuroendocrine tumor?
Yeah, unfortunately, as you know, it's can be tricky depending on where in the lung we're talking about and what the size of the nodule is. So anything less than 8 millimeters can sometimes, it's not easy to biopsy transbronchially. It can be missed even with EBUS. The location also matters. So peripheral nodules that are closer to the pleura, to the surface, are sometimes easier to biopsy from the outside by interventional radiology rather than by pulmonology. So in these, when we get cases that are not straightforward, a lot of the times we convene tumor board, especially in the thoracic group, where we discuss individual cases to come up with a plan that makes sense for that person. Because, as you said, sometimes it can be missed with FNA. And, if we are worried about, let's say, if you need more tissue and we're not sure that an FNA would be enough, especially if you're sending it out for next-gen sequencing and things of that nature, sometimes we want to get a biopsy rather than FNA. So we always make sure that we have multidisciplinary discussions around this, which includes intervention pulmonology, intervention radiology, us, and sometimes even thoracic surgery, because sometimes it's easier to actually take out the entire cancer along with the lobe around it. So these are very nuanced discussions that really require expertise from all the groups that I mentioned.
Yeah, the importance of a multidisciplinary discussion. Thank you, Dr. Sukrathan. Dr. Coons, how common are NETs in the ovary or pelvic wall as metastasis from small bowel?
So I don't know that I have a specific percentage, but I will say that we can see for GI malignancies in general, we can pretty commonly see metastases to the ovaries and to the abdominal wall, which would be called peritoneal metastases. In my experience, we see these more commonly often with small intestine neuroendocrine tumors for the peritoneal mets, but ovarian mets can really happen with almost any GI malignancy, neuroendocrine tumors included, and including pancreatic NETs. These can be tricky areas to treat, and often in terms of ovarian metastases can grow despite other areas in the body maybe being controlled. In peritoneal metastases, I like to describe these as little seeds of cancer that can line sort of the outside of the intestines and the abdominal wall, and they can really slow down the GI tract and can place patients at risk for obstruction. So they do require tailored strategies to think about how to care for patients with these.
Thank you for that, Dr. Coons. This question is about gastric nets. I'll start with Dr. Clark and then Dr. Malak. What scans are recommended after diagnoses with a foregut gastric grade 1 net? This person has an endoscopic ultrasound scheduled, but unsure of what else to ask for. Dr. Clark?
Okay, so gastric nets in particular are very difficult to explain because there are multiple types. And so I'm going to try to do a very brief summary of the multiple types of gastric nets. This is a really tough question, Lisa. Okay, so let's start with there are really 4 types of gastric nets. The most common type is a type 1 gastric neuroendocrine tumor. These are multiple, usually small tumors, typically seen in chronic gastritis or in people that have prolonged PPI use. And they're almost hyperplasias of the neuroendocrine cells within the stomach. And these tend to be more benign and indolent, and they're typically not managed with surgical resection. And they can just be observed with repeat endoscopies, medication modifications, et cetera. And those patients really tend to do very well. Type 2 gastric neuroendocrine tumors are more commonly associated with endocrinopathies that are hereditary. So like MEN1 is a very common association with these. These tend to be multifocal, they tend to be functional, and they don't respond well to surgery because of the multifocality. And we really try to manage and optimize other medical conditions in these patients, somatostatin analog therapy. And again, surgery is reserved for certain cases, but again, may not be the mainstay of treatment for this disease. The surgery really plays a role in type 3 and type 4 gastric neuroendocrine tumors. These are more solitary tumors. They tend to be much larger tumors, and they metastasize at a much more aggressive rate. And so type 3 and type 4 patients, certainly we want to get good biopsy, we want an endoscopy, we want a dotatate scan to look at the extent of disease. If there's evidence of metastasis, we typically delay any surgical intervention and start first with either a systemic therapy with a somatostatin analog or something else, especially if these are higher grade tumors, and then really only use surgery in patients where we think that cytoreduction is going to be beneficial. I think what this person may be referring to is a type 1 gastric neuroendocrine tumor, and those can be observed with endoscopy and occasional EUSs at regular intervals, 6 months to a year, depending on symptomatology, how confident they are in the type 1 diagnosis, and then the number of lesions or the size of the lesion that was initially seen.
Thank you for that fantastic overview. And Dr. Malak, is there anything else you would add to scan recommendations?
So for scan recommendations, typically these lesions are very small, and those are difficult to see with CT and even with dotatate PET. So basically, to look at the tumor itself in the stomach, endoscopy is best, as Dr. Clark described. So those, this person might get a CT, might get a dotatate PET, and we might not be able to actually see the primary, which a lot of times could be very small, especially if it's a type 1. Now, if there is any concern that the disease might be more aggressive than that, or that it might have spread, then a CT and a dotatate PET potentially would be helpful for staging, especially if there's consideration of surgery.
Thank you so much. Dr. Sukrathan, are lung nets different from other nets? Why or why not?
So I think in many ways, starting with from the genomic aspect, from a prognosis aspect, from a survival aspect, from a treatment aspect, there's lots of nuances for lung nets. So maybe just a very quick overview. So first of all, as many of you may be aware, the way we classify lung nets is a little bit different compared to GI nets. So the terms typical and atypical carcinoid that you may have come across. Generally, we have moved away from the term carcinoid in the gastroenteropancreatic space, but as of today, we still use the term carcinoid for the lung nets, and there are historical reasons for it. But there's also these terms typical and atypical, which really they're determined by what the pathologists are noticing under the microscope in terms of mitosis and necrosis, and that plays a huge role. The overall prognosis, how we treat this disease, how we think about this disease. So I think straight off the bat, the terminology is very different. I also want to point out that lung nets are also quite different genomically. So there's been quite a few studies now that have looked at, what are the tumors, what are the mutations that we find in these tumors? And a lot of the times there is some evidence that they're, dramatically different from gastric or enteric or pancreatic neuroendocrine tumors. There is an association with Mailman in some patients, but many of times not. Sometimes we find, a lot more of what's called chromatin remodeling genes that are altered, especially in atypical lung nets. And, there is some evidence that some of these respond a little bit differently to immunotherapy than what we expect otherwise for the gastroenteropancreatic net. I also want to point out that the way we even follow these may be different because some of you may be aware, lung nets are notorious sometimes for not showing up on rotative PET scans. And this is increasingly a concern because, the sensitivity for other nets is so high, but in the lung net space, it's closer to maybe 60% of tumors that are positive on a rotative PET scan. And a lot of the times we end up needing to do what's called an FDG PET scan if a rotative PET scan is negative. And that also has implications for how we think of it in terms of aggressiveness. So, that's a big difference. In terms of treatment as well, so we don't have as much, I would say, robust evidence that certain treatments work in lung nets. So some of it is because being a rarer subset of neuroendocrine tumors, I think we are lagging a little bit behind, specifically in terms of designing trials. And so I would say we are, some of the evidence that we have is more retrospective in nature, and we're hoping that, in the future we're able to correct that. Right now we have a study of Lutathera in lung nets that's currently enrolling in the US. So that should tell us more about how effective it is in the lung net space. And beyond that, even certain drugs like capecitabine and temozolomide have only been studied retrospectively and not in prospective fashion. So there's a lot of extrapolating that we do. So there's a little bit of, I would say, increased. We're not entirely confident about how well these treatments work, but there's a lot of evidence from personal experience, from expertise from centers. So the guidelines are very clear that some of these drugs do work very well and we use them very effectively. But I would say there's a lot more yet to be learned about lung nets, and we're hoping to get more data in the future.
Thank you. The differences underscore the importance for lung nets to be included in clinical trials. Dr. Coons, feel free to comment on that last question, but this question is for you as well. Is it helpful to use systemic treatments other than somatostatin analogs, for example, PRT, Captem, everolimus, cabozantinib, etc., when the disease is still small or limited to one area? I think oftentimes people worry about the spread or the growth, and can we just kind of hit it when it's small?
So that's another really good question. And I would say that my general approach and really consistent with guidelines is that we look for clear indications that are for the physicians to say, what's the trigger for me to recommend a new treatment? And typically that's clear evidence of progression or growth. And this is for patients with metastatic disease. So if we start with a somatostatin analog with the goal of it suppressing growth and controlling the disease, I think as long as a patient is tolerating that and as long as it's controlling the growth of the cancer, I would recommend that a patient stay on that as long as both of those things are true. If at some future point we see clear evidence of progression, we then think about adding or kind of switching to a new treatment. At present time, we don't have evidence to suggest that combining lots of things up front really benefits patients. And in fact, it may cause more side effects. We really think about safety of combinations, and those would need to be studied in clinical trials.
Thank you. And Dr. Clark, I love your input on this question as well.
So I think as a surgeon, where we talk about using systemic therapies upfront before surgery for resectable tumors, we're usually trying to use it for a reason. So either we are trying to test biology, which means this is a tumor that's exhibited some very aggressive phenotypes, whether it's because it's a higher grade tumor or the extent of spread is quite high, and we want to have a higher sense of confidence that the surgery is going to yield good results with a relatively long progression-free survival time so that the operation is worth the stretch because it is a prolonged recovery, etc. Or we're looking to either shrink or downsize the tumor to make the surgical resection a bit easier or a smaller scale so that the complication risk is different and the chance for recovery is a little bit higher. So in that setting, we call it a neoadjuvant approach. And I particularly try to use this whenever I see one or more of those scenarios. So for higher grade tumors or for tumors that have high volume or high burden of disease, even if we're planning surgery, it's always good to feel a little bit more confident that we have some control of the tumor, or we have good downsizing before we do a big operation so that the patient has a maximal benefit. And then we know that we can get them back on that same medication, either to continue to control the micrometastatic disease that we can't see, or just to even assess response to therapy in the event the cancer comes back.
Yeah, thank you so much, Dr. Clark. Dr. Malak, on a CT scan report, as you know, patients often read their reports. Does innumerable hypodense lesions mean more than 20 natural characteristics of the liver, or innumerable NET or neck tumors?
Well, typically, I would assume that they must be like NET tumors, because we do not like use this description for normal liver. And sometimes neuroendocrine tumors do that, like they do spread in a way that there are a lot of lesions in the liver. And typically, there is no cutoff on when this term is used, but mainly when there are like too many to count. And so this term could be used, and then the reader might choose the biggest ones as representative lesions. So they would describe the largest and would follow them over time.
I see many heads nodding, so thank you for that. Thank you, Dr. Malak. Dr. Sukarthan, thank you for your excellent presentation on symptom management. This question is related to that. Is it true that just about everyone taking somatostatin analogs like somatoline depot, lanreotide, or octreotide will eventually develop diabetes?
No, not at all. So it is a small but significant percentage. I think it's probably in the range of around 10 to 15% or so, if I remember correctly. So I don't want people to fear diabetes and not get on a life-saving medication. I think it's just a question of keeping in mind that sometimes we have to control other comorbidities when we start some of these medications. So, we've had some situations when people have really uncontrolled diabetes when I think twice about, whether this is the right time to start an SSA in someone. Because as we know, people can have very long lifespan and very good prognosis with neuroendocrine tumors. And I would hate for someone to develop full-blown diabetes or uncontrolled diabetes, leading to complications like kidney failure or heart attacks or stroke. So this is actually just an informed conversation that I'd like to have with people who have comorbidities that can predispose someone to developing diabetes. But it also means that we work closely with endocrinologists and primary care doctors so that they are aware and they are keeping an eye out for, an A1C that is increasing. And if they're not sure, to reach out to us, because that may be one of the reasons why the A1C is all of a sudden going up. So I think it's just about raising awareness among patients as well as in the community to keep an eye on this potential complication, but absolutely not. I would not say that everyone develops it.
Thank you. And a follow-up question to that, what are the recommendations for treating diarrhea with taking somatostatin analogs?
Yeah, so I think, it's a little bit nuanced because it depends on a few things. The first thing is, where is the diarrhea coming from? So as we all know, there are many reasons why somebody with neuroendocrine tumors can have diarrhea, some of which can be surgical, as we know. And when you lose a significant amount of bowel with surgery, you can develop what's called post-surgical short gut syndrome. That can be one reason. The other obvious reason is when you have metastases to the liver, which leads to carcinoid syndrome causing diarrhea. But also, when you get the shots, we know that especially for the first few days, especially the first few cycles, you can have transient increased diarrhea. So that's another reason. And sometimes breakthrough diarrhea, which means that in some situations, the shot just wears off by the third week. So you really have to be thoughtful about, what exactly is causing the diarrhea. When in the cycle is it? And think about if it is surgical, can we supplement some of these? For example, the enzymes, cholestyramine, for example, is a good drug that we sometimes use. If it is, related to shot related to the first 3 days, then sometimes we consider Creon with the steatorrhea. If the diarrhea is due to wearing off of the shot, then sometimes we reduce the frequency or increase the dose. And we have lots of second order medications like Zermelo and things in that situation as well. So I think it's a question of just kind of thinking about what exactly is going on and being thoughtful about it.
Thank you so much for your thoughtful answer. Dr. Kuntz, are there preventative measures for colitis or gastritis to do before chemotherapy treatment? And is Folfox more gentle than Captem? And what's the average number of cycles?
So we don't know who will necessarily get colitis from chemotherapy, and there's no clear preventive tool. But I will make a comment about both Captem and Fulfox because there has been some sort of things in the news recently. So Fulfox is an IV chemotherapy. The two primary chemotherapies involved are 5-FU and oxaliplatin. It's an acronym that stands for those two. They are given every 2 weeks. The oxaliplatin is given in the office. It takes about 2 hours to infuse, and the 5-FU is infused over 46 hours. Patients go home with a pump in a special bag that they carry in a fanny pack, and it infuses automatically for that 46 hours. Captem are all pills. They are taken 2 weeks on and 2 weeks off. The capecitabine is taken for all 14 of those days, morning and evening, and the Temodar is taken for days 10 through 14 and overlapped with the capecitabine. So capecitabine is actually a cousin to 5-FU. They're really the same kind of active drug. Capecitabine is considered a prodrug of 5-FU, but they're really very similar. Fewer than 1% of patients can have something called DPD deficiency. That is an enzyme that metabolizes 5-FU and capecitabine. This has actually been lately in the New York Times and a lot of press because for patients who have this enzyme deficiency, they can be exquisitely sensitive to these medications, leading to colitis and diarrhea. Many institutions are now adopting a policy to test for DPD. And this is a kind of a genetic test that can be done prior to starting therapy. So patients can certainly ask for that, but many of our institutions are starting to adopt that as a routine practice. So for Captem, typically we will give a maximum of 1 year. We typically do treatments in 3-month blocks. So I'll do 3 months and then a scan to assess if a patient is responding or not. And if patients are either not responding or having really severe side effects, we may consider making some changes. But if they have evidence of progression, we would then stop and move to something else. And the same is really true for Fulfox. Fulfox, we would continue as long as patients are tolerating it and as long as it's working. Fulfox is harder, I have found, than capecitabine temozolomide, specifically in terms of neuropathy. So that can be numbness and tingling in fingers and toes. And we're often limited to give that treatment for maybe 6 to 9 months, but it really varies depending on an individual patient.
Yeah. And I'm just curious, is there a certain point where you plateau the maximum benefit? So would you continue it all the way up to 1 year if someone's receiving maximum benefit, or if they have tumor shrinkage at 6 months, you would kind of stop early for Captem?
Yeah, so the clinical trial that sort of led to us using this as a standard treated most patients for a year. But I think that's an excellent question that we don't really have a lot of high-level evidence for. But I would say typically we would treat for at least 1 scan beyond kind of the maximum benefit. And that tends to be around that 9 to 12 month mark.
Thank you so much for that excellent overview. Dr. Sukrathan, should most NET patients have the 5-HIA test done?
I think it's a little bit institution specific of a question because some institutions have plasma 5-HIA, other institutions only have access to 24-hour urine 5-HIA. So again, I think it's not a broadly generalizable answer, but especially in the beginning when folks come with certain symptoms, which may or may not be entirely related to the carcinoid syndrome, I do like to check a level in the beginning because, in some of the situations that I alluded to, if you're not sure where the diarrhea is coming from, or if the flushing sounds somewhat familiar and is very similar to, let's say, menopausal symptoms, there are instances when it is a good idea to check it. But I think a lot of the times, if you have a very obvious carcinoid syndrome qualifying diagnosis, you don't really need to check it, in my opinion, especially if it's a 24-hour urine 5-HIA. It can be quite difficult to monitor serially. We have quite a few patients who find it very difficult to collect urine over 24-hour time span, and they express to me how difficult that is. So I tend to be very sympathetic about some of the logistical challenges associated with that. So, we do check it, especially if I'm concerned about, whether someone has a carcinoid syndrome or not. And also if I'm concerned if they are starting to develop things like, let's say, a worsening of their symptoms, but if a scan looks very stable. So there are certain situations where it does make sense to monitor, but I don't routinely do it for everyone, let's say with every scan, because I don't think it adds that much information.
Thank you. And a follow-up question. In order to prepare for that 5-HIAA 24-hour urine test, which you mentioned was very difficult to collect, we must avoid avocado, walnuts, tomatoes, since they're high in serotonin. So should I always avoid these foods to prevent net tumor growth?
No, because it has never been any study to show that eating avocados makes your nets any worse, right? And I don't think there'll ever be a study like that. I don't think it's actually biologically plausible. I think a lot of the reasons why we do this is because we want to make sure that we don't want to get false positives that are just above the level of normal. And that can be very different based on where you do the test. I also tell people something similar about chromogranin, that the level itself is not harming you in any way. It's a surrogate for what the tumor is doing. Unfortunately, it's a poor surrogate. And I would say that also for HIA as well. So no, I don't think you need to, restrict. I mean, that would be a very draconian diet to follow and probably not even realistic and against the principles of, having a good quality of life. So I would not recommend anyone avoid these delicious food items.
Food matters for quality of life. Thank you for that. Dr. Malak, considering a whole body dotatate PET scan the morning of liver ablations with the hope that enough of the dotatate remains on board for ablative guidance, how long is the dotatate able to visualize the nets for ablation guidance?
Because I'm wondering whether the imaging at the time of the ablation is using the dotatate itself, or what my guess, like sometimes we do that where we do procedures under PET CT, but that's a very complex setup and workflow. What I guess most places would do instead is basically image the PET CT in the morning, and then they would target the CT correlate of that lesion for ablation later on. That's my guess of how that would go. Now, how long the dotatate will stay is depend on what we're using. So a gallium-68 has a half-life of 68 minutes, and typically after 10 half-lives is when you basically don't have much left to be seen. So if it's only after like a few hours, then there is still signal on board. If copper-64 is used, it has a much longer half-life that it will definitely still be on board later on. So it's just a few hours between the PET scan and the ablation, then enough dotatate will be on board to be able to see them with PET. But my best guess is that the correlate of the lesion that we're seeing on the PET is what's being targeted on CT. That's my best guess of how the procedure would go.
Thank you so much. We'll end with this last question, and I'll have Dr. Kuntz and then Dr. Clark answer this. How common is it for the cancer to change grades, and what causes it to change?
So I think we've learned a lot about this question in the last 5 to 10 years. And I think that we do now recognize that neuroendocrine tumors can change grade over time. And I think that I will base decisions on what's happening with scans for individual patients, and will make a decision as to whether or not to rebiopsy based on whether a clinical behavior, meaning does the cancer grow more quickly than what I would have imagined based on the original biopsy? And if that answer is yes, then I would consider rebiopsying. So we can see a kind of increase sometimes with a Ki-67 that might inform and change what types of treatments I select. And I think that there is an increasing recognition that getting repeat biopsies at time of real rapid pace of growth or change that's different than what we would expect, that is being done more commonly now. But I'll pass to Dr. Clark.
Exactly correct. We have a paper that we're working on right now that's essentially showing that the correlation between the primary tumor grade and the metastasis is much higher if patients present with both sites of disease at the same time. We call that synchronous metastases, versus patients that develop metastases later on, maybe even separate or years from surgery for their primary tumor. And we call that metachronous metastases. And so why does that happen? I think for a variety of reasons. I think that there is treatment selection. So as you have neuroendocrine cancer and you've been treated with multiple lines of therapy, different medications, we believe, are very effective at treating certain groups of cells. And so sometimes what you have are the cells that survive. And they may be different than the cells that respond to treatments. And sometimes those cells can be a little bit more aggressive. And so we can see a change in grade over time, maybe from treatment selection or pressure selection of the cells that are surviving, and then also just time as the tumors change. A good reason that we love to see where a tumor grade can change is after a neoadjuvant treatment. For example, we will often treat, high grade tumors, grade 2, grade 3 tumors with therapy. And, we tend to use, especially for pancreatic neuroendocrine tumors, CAPE-10. And then we'll have patients that have had a really great response. They still have some disease somewhere else. And it's just so rewarding when I take them to surgery and everything that we remove is grade 1. It tells us the CAPE-10 really did a good job at taking care of the higher grade disease cells, and sort of what was left behind was lower grade disease. I think it's a really good indication for response to treatment as well, and sometimes can portend to a better progression-free survival for patients that have these more aggressive tumors. So I think time is one big factor for why grades change, and then treatment response is another really big factor for why grade may change over time.
Thank you, Dr. Clark and Dr. Kuntz. I want to thank Drs. Clark, Kuntz, Malak, and Sukathan for your time and thoughtful answers. And I'm going to invite the second group, Josh Mailman, Dr. Carreras, Chan, Chauhan, and Mitra, to turn on their cameras and join us for the question and answer session now.
Thank you very much, Lisa. Very informative first set of questions. We have a lot of questions here that are PRRT and both in general as well. So we'll get right at it. The first one we're going to ask, and Dr. Chauhan, you really covered this well, but the incidence of developing MDS following PRRT, does this increase over time? Is understanding, how this risk compares to other treatments that we may be on as well.
Great. Thank you, Josh. Thanks everybody for the invitation. Great question. Some of this we have yet to fully uncover and understand. As of today, the best data we have is probably NETTER-1, where they had reported out 6 to 7 year follow-up data for long-term safety. And based on that study, we can say that the risk of acute myelogenous leukemias is less than 1%, and the MDS is in the range of 1 to 2%. This is also inconsistent with the larger European data, which usually suggests the range in 1 to 4% based on individual institutional studies. So it's very reassuring that the long-term bone marrow side effects are in that range. Having said that, we are entering a new era of neuroendocrine cancers where patients have now been treated on several lines of therapies. In fact, several types of PRRTs, even under research, alpha, beta, and repeat beta. So certainly these data may not fully reflect the realities of the new age, or the next 10 years. So I think we need to continue to learn and reassess. But as of now, the risk is relatively low. This risk may actually be accentuated if there are certain risk factors. For example, if there's a personal history of leukemia, lymphomas, history of prior use of chemotherapy, especially alkylators. These are a type of chemotherapies that especially damage DNA and the bone marrow. So the risk is a little bit heightened. In fact, there was a retrospective series presented at ENETS recently, which suggested the risk of MDS to be as high as 8%, especially if there is cumulative risk factors of prior chemotherapies like alkylators in the past. But this is not an established fact yet. I would not like to dissuade or scare patients away with this. I think the risk is still very low based on the best studies and best evidence we have. However, this is leading us to study this in more detail, and there are technologies in development. For example, CHIP technology stands for clonal hematopoiesis of indeterminate potential. So these are a set of mutations or genes that we look for and we understand may predict the risk of MDS, and that has to be validated in neuroendocrine tumors. It has been validated in some other cancers. So we are looking into it, and there are some tools that we can rely on. As of Today, the risk is low. Some of the telltale signs would be advanced age, personal history of leukemias, or prior exposure to alkylator-based chemo for a prolonged period of time. But these are not validated, or I would not preclude anybody from getting PRRT just because they had CAPE-10 in the past. Those are my 2 cents. I'd like to hear my colleagues, Dr. Chan and others.
Dr. Chan, how do you really talk to patients about this?
Yeah, I think I agree with what Dr. Chauhan has mentioned. I think the risk of leukemia we have seen is quite low, less than 1% over time. The risk of myelodysplasia, which might be a precursor to leukemia, might be a slightly higher than that. I think these are just risks we need to be aware of and to monitor for any changes in blood work that might indicate that there's been some insult to the bone marrow. There are some, as Dr. Chauhan mentioned, possible risk factors that may predispose people to the higher risk, like prior alkylating agent chemotherapy. But I'd say that as we make decisions, it's just important to recognize these risks. But ultimately, we're also trying to balance that risk with the real benefit that patients may derive from PRT to control their cancer. Some of our chemotherapy agents can also predispose people to leukemia or MDS. For instance, even the alkylating agents by themselves, even without PRT, may cause bone marrow damage. And chemotherapy agents like etoposide also can raise the risk of leukemia and MDS. Everything to be aware of. These risks are small, and I think those risks are outweighed by the real benefit of the treatment.
Following up, you talked a little bit about doing chip testing. How often does this happen in the real world as far as this point, or other predictives to see if we can at least move patients who might be predisposed to MDS or AML away from PRT? And Dr. Mitra, do you do this in your practice?
No,
Right.
no, we don't. Yeah, I would echo, what the others have said, is that we know that there are some risk factors and there's some things to keep in mind, but we don't have enough information at the current time to really make decisions around avoiding PRT, which we know is a very good treatment, and so if the patient is eligible for that, I think primarily we will go for it.
How do you counsel patients into what's right for them? I'm very curious for those of you who have both the alpha repeat trials and the Lutathera repeat trial, as well as other things that may become secondary treatment after PRT. How do you do that? I mean, what's the criteria that you use?
Yeah, I'll start off, Josh. I think this is a great question. I think the fact that there are so many trials is really exciting. I think all of these trials, we hope, will lead to more knowledge and potentially even more treatments. I think as we counsel patients, we always will review what the standard options are, because there are, as you know, an increasing number of standard options that are on the table. There also are trials that may be relevant for patients, so we'll consider their situation and whether they may be a candidate, for instance, for one of their PRT retreatment trials. And I think not all centers have both trials open, so we may be able to offer what is available at our own institution and point out what also may be being investigated for the field. I always encourage clinical trial participation if that's something that patients are interested. I think this may be a way, again, that we can, as a field, learn more about some of these newer treatments that may be better than what we currently have. I think patients may be interested in participating in these studies because it also gives them access to some of the newer, really interesting agents that are being investigated. But I think for me personally, it's a matter of just laying out all the options that are on the table, the standard options and the trial options, and then we'll discuss the pros and cons and ultimately arrive at what people feel most comfortable doing.
Josh, if I may add to that, I completely agree with Dr. Chan. I think as an overarching, while having the discussion with the patient, I, in general, advocate for clinical trials. We have come from an era during my training where we didn't have access to PRRT, and patient routinely used to travel abroad to get this drug. So clinical trials, the best way, is the most scientific way to advance science, which will help not only our patients, but the next generation of patients and the field in general. However, not all trials are the same. And that's where the nuance comes in. If we are dealing with a phase 1 trial, which is a dose escalation, and we have a very good standard of care treatment available, we need to make that clear to the patient. And if there is a trial with a placebo arm, is the patient comfortable to take that risk of being randomized to the placebo arm? So those are the things that we have to disclose to the patient. At the end of the day, we are patient's physician first and the trialist later. Having said that, most of the trials that are designed with the spirit that we are advancing on the current standard of care, that we are going to improve either the drug or the target or the side effects, or there is some improvement of the current standard of care. So, it's good that there are access to the trials. 90% of patients, if not more, will not either qualify for the study or don't have access to the study. These are just national statistics. There's very few patients who have access to the studies. So yeah, it's good that we have trials to offer. We kind of tell the trial, not all trials are same. Phase 2, phase 3 may have more clinical data backing them up. Phase 1 are a little bit earlier, and these are usually reserved for patients who may have exhausted all standard options.
Dr. Carrera, was fascinated with your talk and talking about something that we don't talk much about in the United States. And I know you trained a little bit in Europe with Dr. Baum, the terbium and Auger electrons. What have you seen about them? I know that there's a few clinical trials going on in Europe on terbium 161, and it may be one of those radionuclides that becomes more available as time goes on versus some of the other challenges we have with alpha production.
Thank you. Thank you for having me, and thank you for the question. I think that this Auger electron therapy will have a more importance in the future because it's really interesting how it works. Actually, beta minus emitters are less probably to hit both of the chains of the DNA, and the lethality of this kind of treatments is not as high as with alpha emitters or with Auger emissions. The results of the studies with this kind of treatments are amazing, actually, but all these patients have been treated before with lutetium. So I think in the future will be important to learn what happens when we treat the patients with terbium 161 first, because normally when the patients are not responding to lutetium, then they are switching to the other kind of treatments. And that means that the patients are already high risk or not as radiosensitized as they should. So the most important point of this terbium therapy is that the linear energy transfer of this kind of therapies is really high. So in the first place, we have alpha therapy. It's the higher linear energy transfer. And second one is the Auger electrons, but the advantage of this terbium or Auger electrons is that they hit in different directions, not just in one direction. So that is helping a lot in patients with bulky tumors.
And it also may be easier to produce and more availability. I will say one of the questions that came up both when talking about trials is, and we didn't really get that from the earlier presentations, is how long does it take for these drugs that are in trial to actually come to the market? What's your best guess of how long that might be? And things that are in phase 2 might give us some, not crystal balling because each drug is different, but just some idea of just how long that does take before they get into general practice if everything is successful. Dr. Chen, I realized that you just went and got a new indication for a drug that had already been approved. And how many years did that take from the time your phase 3 trial opened?
Yeah, Josh, thanks for that question. I think this is a really important point. So the CABINET trial studied the efficacy of cabozantinib in patients with advanced neuroendocrine tumors. And as you mentioned, just led to the approval of cabozantinib in March of this year. The trial itself opened in 2018. So it took a good 7 years to complete the study and to ultimately have the FDA approval, which I anticipate and hope will expand access to treatment. I think for trials moving forward, that is a long period of time. I think that's where having more sites participate, having the trials open in a kind of more global way may also help to speed the recruitment and complete the trials in a much faster way. But it can take several years to actually enroll the trials and then have the trials read out for the outcomes that we're looking for.
Stress. Does this actually impact our disease progression or our disease at all? Other than it's not a great quality of life measure to have stress, but how does it impact our actual disease? And Dr. Chan, I'll go back to you on this.
Yeah, that's a really important point, Jess. I don't know that there have been many studies that have really looked at whether stress will, for instance, make the cancer grow or spread faster. I think you point out one thing that is really important is that we know that it can impact mental health and quality of life. And for some patients who may have carcinoid syndrome, that stress can also provoke more symptoms of flushing and diarrhea that also are probably tumor related. So there probably is some impact of stress and the physiologic changes with stress on the cancer itself. But I would say that we don't know yet that actually makes the cancer worse and grows faster and spread. But it is really important to try to manage the stresses as best we can with medications, with counseling, with other interventions, because I think that ultimately will impact and improve quality of life.
Back to our radioligand questions or PRRT questions, we talked about already MDS and AML, but the use of PRRT when people have bone mets seems counterintuitive, but why does it work or does it work? And are we more concerned with metastatic disease to the bone developing MDS or AML?
So the nice thing about the systemic therapies, including PRRT, is that they will circulate everywhere and target all the lesions that we see. When we're talking about PRRT in particular, it will go to all the areas that we see uptake on the PET scan, which often includes bone metastasis as well. And so it will target those areas. Generally speaking, both what we've seen in the literature as well as my own experience is that if there are more bone lesions, it doesn't actually lead to more side effects in terms of toxicity to the bone marrow. And it's thought to be that the toxicity is actually more related to the general circulation of the radiopharmaceutical, which will happen for all patients, not necessarily the subsequent targeting to those bone lesions. So we actually don't worry about that side effect more in those patients. On the other hand, as I mentioned, it is targeting those areas, so it's nice to be able to treat all the areas of disease that we see on the PET scan rather than only certain areas.
Yes, I totally agree with Dr. Mitra. And I also want to add that in my clinical practice, we perform every patient, every time, a dosimetry. So we perform a SPECT CT after each cycle of PRRT. And afterwards, we make all these calculations for dosimetry. And we have found very useful to do this kind of studies, at least after the first cycle, to predict more or less what is going to happen with the bone marrow, and not only with bone marrow, but also with kidneys. For example, if we are blocking properly the receptors in the kidneys with the amino acid solution, and it works until now very well, not only for neuroendocrine tumors, but also for prostate cancer patients. It's working very accurate.
I know this isn't always commonplace in the US, but you lay out two great reasons right there for why having post-therapy day of or day after SPECT CT is important. Does it also predict whether the treatment will work well, or is it just more of we get the dosimetry data to look at, as you said, distribution in marrow, kidney, also calculate what areas got what doses?
Yes, actually, I think is the most important part of the dosimetry is this one, if the patient is going to respond to the treatment or not. We have some cutoffs for predicting if the patient will have a good response to this kind of treatments or not, but the cutoff is not already properly set. We need to make a lot of trials and a lot of expertise is needed here. For example, to decide if I get, I don't know, maybe 5 grays or 6 grays each cycle, should I continue with the treatment or not? It's not already set up.
Just to make sure that everyone understands that, these things that Dr. Carreras is talking about, while very kind of state of the art and cutting edge, there's also a lot that is unknown about them. And so a lot of it actually falls kind of more onto the research side a little bit. We're right on the cusp of kind of bringing this into the clinic, I would say. So at our institution, for instance, we don't routinely do post-therapy SPECT imaging, and we do dosimetry, but only on specific patients. For instance, we were talking previously about this kind of additive cumulative toxicity potentially from lutetium therapies as well as subsequent alpha therapies or what other things. And dosimetry may well give us a lot of information about those types of things and to be able to avoid toxicities. But I also want people to understand, if you're not necessarily getting a SPECT CT, not necessarily getting dosimetry at your institution, that's also completely fine. There's a lot of heterogeneity throughout the US and throughout the world on these topics. And again, at our institution, we on purpose choose not to do those things because we feel like it's not necessarily clearly indicating which way to go with the therapy.
So one of the other things that came up, and it certainly was in the question and answer in the earlier session, is the talk about when to get the final post-therapy scan, whether it's a CT, conventional imaging, or DOTA, but how many months do you wait after? And there's this worry about pseudoprogression and how to work with and know whether what might look like some progression be pseudoprogression versus actual growth. And I certainly read one study where the number of those who reported pseudoprogression versus the number that actually had progression were pretty similar. And I think both are important. The question actually in front says, should we wait 8 months and from the time of the last treatment? And that would seem to me to be a long time between the last time I took a look at an image to, things can happen in almost 2 years if you go to 8 months. So how do you look at this? Or is this a case by case, how people are dealing with their symptoms, other blood markers and things like that? And I'll ask all 4 of you because it may be independent of practice as well.
Yeah, I think, I'm sure we could all chime in on this question and all provide a slightly different version of the answer, because this again falls into this kind of category where there are no clear guidelines. There's some suggestions. And so absolutely, it's kind of patient specific to some degree. It's also institution dependent. So there's going to be a lot of variability there. But I completely agree with your comments that, you do have to be concerned about pseudoprogression. And that's one of the reasons, for instance, at our institution, why we choose not to do too much imaging. For instance, some places will do a repeat PET scan or conventional imaging after 2 cycles of PRRT, but we choose not to because we're concerned for that. We actually do post-therapy imaging after 3 months, after the last cycle of PRRT. But even with that scan, we kind of keep in the back of our minds that there might be some possibility of pseudoprogression, particularly on the PET scan. There's no response criteria established yet for dotatate imaging, so we don't really know what changes in SUV uptake, for instance, mean. What we can rely on typically is growth of tumors on conventional imaging that would indicate true progression. And then the 8 or 9 months post PRRT scan is definitely recommended, sort of a new baseline. But as you said, a lot can happen in between that time, so we sort of advocate for some additional imaging in between. But yeah, if the others want to chime in, I'm sure you'll get several different answers.
Yeah, Josh, this is one of those areas where I think there's a lot of heterogeneity in our practice patterns. For my practice, if it is a higher grade tumor, so now we know based on NETTER-2, we can treat grade 3 and higher grade 2. Those are more aggressive biology, and I don't feel comfortable waiting 6 months or 8 months knowing what's happening because those tumors can grow very fast. So I oftentimes will do a first anatomic scan, that is a CT or an MRI after 2 doses. But this is a very unique subset. This is a higher grade, more aggressive disease. We may even consider even before that, based on clinical symptomatology, there are some patients who would not just respond to PRRT, and that's a very smaller piece of pie. But if patients continuing to lose weight, they are getting symptomatic, you're not going to just give them another PRRT, wait 4 months and get a scan. You have to act on the clinical judgment. But for majority of patients, and we are talking 80% plus patients which are grade 1 and low grade 2 slow growing indolent disease, I think it's an overkill to do a scan too early. Now, I've personally participated in 3 prospective ETCT and Lutathera studies, ETCT 10388, 10450, and now we're just about to complete 10558, and cumulative treated close to 160 patients. And in the trial, we are mandated to do scans every 4 months. So we were kind of privy to all this frequent scans. And the first scan is almost useless because there's really no clinical determination. It's almost always either stable plus minus a little change. So the plus is pseudoprogression from the inflammation, from the radiation. So it really is not very helpful in guiding care. We had to do it. It's a part of research. So for routine standard of care patients, I oftentimes wait after the 3 cycles, a month after. So that gives us enough time for the treatment to work and get some sort of early information. And the real value is after all 4 doses, then I usually wait 2+ months to get a post-treatment PET scan. So I can show the patient before and after the PET scan and the whole 8-month journey that they had, 8+ months. And that's something that I personally use. There's no clear guidelines then what needs to be done. I think this is something that we should standardize in near future.
I think my approach is similar to what Dr. Chauhan had mentioned. I think for patients who are starting treatment and there is, I would say, fairly significant progression going into treatment, I do tend to look after 2 cycles, right before that 3rd cycle, because I think if you do end up waiting until after all of the treatment is done, well over 6 months has passed. And I think it's probably helpful to look before that degree of time has passed. But I completely agree with the points that both Dr. Mitra and Chauhan mentioned, that it's usually the most important is what you see a couple months after the treatment is done.
I think it's really important what Dr. Chauhan had said, that after the first 2 cycles, it could be a little bit tricky to decide if the progression seen in the PET-CT is real or is like a flare, so due to inflammation or other kind of things. So yeah, we have to take this with a lot of care.
Right. And also what's going on with the patient at the time. I mean, after the first cycle, if they're really sick and other markers seem to go, you would probably look to do something else or look to do some imaging to see if you could see something else. There's a question, are there any clinical trials available for Canadian for NET patients? And I know, Dr. Chand, you're on the repeat trial with Dr. Simran Singh. Dr. Kuntz is on the NETTER-3 trial with Dr. Singh as well. I just want to tell all the patients that the NCF has a clinical trial finder where they can put their location in anywhere in the world, not just Canada or the US, but it will return based on who they are and what they are, that whether there's a trial and how close a trial is. But you've had the pleasure of working with the Canadian trial group. Do you want to, Dr. Chand, do you want to mention that through your NCI experience?
Yes, I've been working very closely with CCTG, the Canadian Cancer Treatment Group. That's the cooperative group that undertakes federally funded studies in Canada. And we have access to NET retreat studies. So this is a patient population who progressed on standard of care Lutathera and have benefited from it. And currently, the approved treatment is only 4 doses. So many patients now are finding challenges in getting additional Lutathera approved either through their insurances. So the trials is a great way to kind of get access to these PRRT products. The other study is Action 1 study, which is also available in Canada. Having said that, my personal observation is as compared to options available in the US, the trial options Canada are limited. So I would highly advise or advocate the Canadian patient groups to advocate and collaborate with like-minded people like Dr. Simran Singh. He's a great champion for NETs patients, and they have a great community, the CNETs community there. Empower them so that your legislation, the government, allow more drug development or more trials. This is a very common problem, and I learned more so when I moved to Miami, because many of my patients, they come from Canada during winters, and it is challenging to find many trial options in Canada, but there are some, and advise you to please link with these high volume centers in Toronto and other areas to learn more about that.
And the challenges you have in Mexico with the number of trials that you have?
Yeah, that's really complicated for us in Mexico because at least at this moment we have no trials involving PRRT. So the patients who are treated with this kind of medicine like Lutathera or another kind of somatostatin analogs labeled with lutetium, they are paying out of their pockets, or sometimes their insurance company are paying for them. We also have national institutes of health, like National Institute of Oncology or Nutrition, and they have some internal trials, but not involving PRRT, just another kind of treatments for neuroendocrine tumors, surgery, radioembolization, and embolizations like Professor Gabuti had already talked about in the morning, and also chemotherapy, lanreotide, and all these kind of treatments.
I'm going to change it up for our last question. In the neuroendocrine tumor world, what is giving you hope? What keeps you driving forward? I'll start with Dr. Chan.
That's a great question. I will say, having been in this neuroendocrine field for close to 20 years, I think there has been tremendous progress that has been made. That gives me hope, and I see a lot of progress being made in the future as well, as we think about the number of clinical trials that are being done, the number of new agents that are being investigated. And I think as a community, we've grown a lot. I think patients have become more connected, and I think they have brought us also together as a community. So the fact that we're all united with a common goal of just advancing treatment, advancing science, and just really trying to improve lives, that I think it motivates and gives me a lot of hope.
Dr. Mitra.
Well, Dr. Chan said it very, very well. I think all of those things are exactly what also give me hope. But I would especially highlight the community. I think this community, both on the professional side as well as the patient side, it's really a wonderful group of people all around. And I think the investment that everyone is making into the neuroendocrine space is what really gives me hope.
Dr. Carrera?
I started learning about neuroendocrine tumors in 2010 with Professor Baum in Germany. And he was really angry because it took like 20 years to come from research to the real life, for example, the Lutathera. And now everything is going faster thanks to the clinical trials and all the effort made by the physicians and, of course, the patient community that is pushing really hard.
Dr. Chan, I'll give you the last word before I turn it over to our studio.
Thank you, Josh. So two precise things definitely get me motivated. One is the patient advocacy groups, Neuroendocrine Cancer Foundation, yours, NorCal CarciNet, NetRF, NCAN. There's so many, and that's really has galvanized the whole field and catapulted the field and pushing industry, academia towards doing more research. And the second thing is the number of new drugs in the development. This wasn't the case 10 years back. These days, we don't have time to see and discuss and meet all the people we can. This is a great problem to have. So I'm very, very excited about what's coming up and for our field, and keeps me up and running. Thank you.
And watching all you guys do the work you do gives me great hope as well. And with that, I'll turn that over to Mary and Dr. Hendafar back in the studio.